Good morning, ladies and gentlemen, and welcome to the November meeting of Adult Wellbeing and Health Overview Scrutiny Committee for the County Council of Durham. My name is John Robinson, I chair the committee. Ladies and gentlemen, this meeting is being recorded live to the Council's website and will be available to be viewed for a minimum of 6 months. Please be aware that any footage from the meeting may be used in subsequent broadcasts by both us and the media. I would like to give a warm welcome to members, officers, and any members of the public or media who are watching this live feed this morning. Before we commence with the formal business of the agenda, may I cover some of the housekeeping issues for us all to follow. Will all participants mute their microphones? Please blur your background wherever possible. To speak, use the chat function on the right-hand side and type in RTS, request to speak. Please remember everyone in the meeting can see the messages in the chat function. When invited to speak by the chair, please remember to unmute your microphone. Once invited to speak, please introduce yourself with your name and position unless you've already introduced yourself previously. If you are having issues with the connectivity, try switching off your video and just use the telephone function. If connectivity issues continue, you may have to leave the meeting and rejoin. Finally, if my connection is lost, Councillor Mr. Rob Croot, Chair of the Corporate Overview and Scrutiny Management Board, will take over until my connection is reconnected. So, ladies and gentlemen, before starting the meeting, I would like to welcome and introduce a number of key officers supporting today's meeting from Durham County Council, NHS County Durham CCG, the County Durham Care Partnership, and Tees and Esquire, Tees, Esk and Wear Valley NHS Trust. Ladies and gentlemen, it's quite a who's who, so here we go. Can I welcome Jane Robinson, the Corporate Director for Adult and Health Services, one of the busiest people in the county, Amanda Healy, the Director of Public Health for Durham County Council, Jenny Howarth, Head of Strategy for Durham County Council, Rachel Rooney, Commissioning and Development Manager for the NHS County Durham CCG, Sue Jakes, the Chief Executive, County Durham and Darlington NHS Foundation Trust, Gillian Curry, Head of Communications and Charity, County Durham and Darlington NHS Foundation Trust, Sarah Burns, Head of Integrated Commissioning, County Durham Integrated Community Care Partnership. Welcome to his new role, his new job and his first meeting, Michael Lang, Director of Integrated Community Services, County Durham Integrated Care Partnership. Jennifer Illingworth, the Director of Operations for Durham and Darlington, Tees, Esk and Wear Valley. Lee Alexander, Head of Adult Services, the DCC. Jane Sunter, Public Health Strategic Manager, DCC. Karen Burns, Strategic Development Officer, Adult Care Transformation. Councillor Jean Chaplow, the Vice Chairman of this committee. And Councillor Lucy Hovels, the Cabinet Member for Health. So, ladies and gentlemen, we have a range of people who this morning will be able to hopefully answer any questions any of us have. So if we can begin, first of all, Jackie, could we have apologies, item 1?
Thank you, Chair. We've got apologies from Councillors Joplin and Reid.
Thank you. Item 2, I believe there is no substitute members?
We've got no substitute members today, Chair. Thank you.
Thank you. Item 3, the minutes of the meeting held on the 2nd of October. Please may we have and agree the minutes is correct? Yeah, I'm getting agreements. Thank you very much, Councillor Smith, Councillor Craythorne. Matters arising. Stephen, would you like to come in at this point?
Chair, before I do, I've just noticed there are 2 requests to speak. If that's on the accuracy of the minutes, I'll defer until those members have come in.
Thank you very much. Councillor Mrs. Tucker.
Thank you, Chair. Tanya Tucker, representing Woodhouse Close, Bishop Auckland. I've just noticed when I was rereading my minutes a couple of errors on page 13, if we may. The paragraph that begins, Councillor Abel agreed swing. I don't believe he was dancing during the meeting, so I think that should say sing without the W.
And your next one, Tanya?
And the third line down, fourth line down, I think there needs to be a to, TO, before present themselves, just to make it grammatically correct, if that's possible.
Thank you very much.
Thank you.
No, thank you. Councillor Temple Owen.
Chair, thank you. Councillor Owen Temple from Concert. Mine was actually a matter arising. It may be that Stephen is going to deal with it. It was not Shotley Bridge. Shall I wait till after Stephen and perhaps you could bring me back?
I will remember, Owen. Yeah, because Stephen is definitely going to focus in on Shotley Bridge, so we'll do both if you don't mind. Thanks, Owen. Stephen?
Thank you, Chair. Stephen Gwillim, Principal Scrutiny Officer, supporting today's meeting. A couple of matters arising I want to bring to members' attention, Chair. The first relates to minute number 9, and that was our consideration of the committee's review of GP services in County Durham. It's just to advise members that that report is being tabled formally at a meeting of the County Council's Cabinet next Wednesday, so we'll get that through Cabinet then. And then secondly, Chair, is another matter arising, and it relates to Shotley Bridge Community Hospital. Obviously, we had an update report from Rachel Rooney from the CCG at our last meeting, following which there was a number of announcements made by government and associated media and press coverage. So, Chair, just to update members further on the position with regard to Shotley Bridge Community Hospital, we have invited Rachel to attend this morning's meeting, Chair.
Thank you, Stephen. Good morning, Rachel, and thank you very much for joining us on this early on a Monday morning. Would you like to address the meeting now, Rachel, please?
Yes, thank you. Good morning, everybody. Just a quick update in terms of that latest comms which came out after the last scrutiny committee. I just want to give members a bit of an update in terms of the timeline. As you will remember, there was an original bid which was submitted in 2016 for the capital funds to re-provide the estate of Shotley Bridge Hospital. If you remember, we tested some of our early thinking in terms of the clinical model in spring 2019. And the idea was that we were going to bring those ideas forward to further engagement in September this year. Obviously, with COVID, we took the opportunity to revisit that clinical model. And again, we'd anticipated engaging in November this year. Later in October, we received some communications from the Department of Health, which suggested that Shotley Bridge Hospital was part of the 40 hospitals nationwide, which would receive capital funding. Some really positive news. However, it did bring about some confusion in terms of the process to take things forward. So we are conferring with NHS England, NHS Improvement, to make sure that we are all using the appropriate process to take that forward. And therefore, we propose to engage in the coming months on that. And again, we're still hopeful that we can consult in the summer of next year, with our final completion date aimed for 2024.
Thank you, Rachel. Rachel, I think this has been a project that has been united across all political parties, all political spectrum, and also supported by all parts of the health to address the issue. And I'd like to thank, on behalf of us ourselves, the councillors and you and your colleagues for getting us this far. And I hope this united working together continues across the Shotley Bridge Members Working Party and ourselves as Scrutiny. So it's one of them success stories, Rachel, where we'll hopefully, working together, achieve a new hospital. Thank you, Rachel. I've got Councillor Richard Bell.
Thanks, Chair. Councillor Bell from Barnard Castle West. Just on the minutes on item 7, the local outbreak management plan, we had a bit of a discussion on granular data down to ward level, and I'd said I struggled to find it on the Durham Insights website. I did manage to find it with Stephen's help, but it's not straightforward, and I think we're still awaiting really a one-stop link that takes you directly to the relevant data. It's kind of in there, but unless you talk through it, it's not very clear how to access it. And I just wondered if there'd been any progress on that front. Thanks, Chair.
Chair, would you like me to come in on that point?
Certainly, Amanda.
Thank you. I mean, obviously we have been updating the dashboard regularly. The middle super output area is on, I think, page 7 or 8 of the dashboard. We have put the dashboard much more prominently on Durham Insights, and we've also had agreement to set up 3 member development sessions to actually take members through the dashboard and the data and to take feedback so we can continue to improve it further. So we're just in the process of getting those dates set up. In addition, what we also do now, Chair, is we send out a bi-weekly update to all members, which does include the latest figures. So hopefully we are improving, and I know our access and our transparency in data is very good compared to many authorities. But those 3 development training sessions, I'm sure, will also help members, and we'll take that feedback on board and continue to improve it too. So dates should be out very soon, and hopefully with some improvements already made from the last scrutiny meeting.
Thank you,
that's very helpful.
Thank you, Richard. Thank you, Amanda. I think you'll be inundated with the members wanting to come on. Sorry, Owen, I brought Richard in because he literally pinged RTS as we were talking about Shotley Bridge. So I do owe you an apology for not bringing you in first. Owen?
Thank you, Chair. My query actually, and of course I'm extremely pleased with the continuing progress on Shotley Bridge and the, as you say, united political front, because it's not a political issue, it's a community issue that we're all behind. My query was actually about page 8. It was a question that I asked, and I don't think it's addressed later in the agenda, so I wondered if it could be addressed now. And it was one which you yourself came back on. It was about visiting to care homes. And the minute actually says that in response to the question, it would be brought back to this meeting. If you remember, you chipped in and said, yeah, well, we have the problem with hospital visiting as well. So I think government has created some new rules on this, and I wondered if we could have an update on visiting. Sorry, did I get lost there?
We did lose you, yes, sir.
Sorry, can we have an update on visiting to hospitals and care homes? It was in page 8 of the minutes.
Jane, you've got your hand up, so I take it, Jane, it's you that's going to answer.
Thank you, Chair. Yeah, good morning, everybody. I'm Jane Robinson, the Corporate Director for Adults and Health. I can certainly answer in terms of the care homes element on that, Owen, and it may be that Sue wants to come in terms of hospitals. You're right.
Have a hand up, Jane, so you're right. You're
Brilliant. Right. OK, thanks for that. So the guidance you referred to was published, I think, just at the end of last week, Owen. So we're just looking at the details of that and reflecting on that. So my suggestion would be, if it's OK, Chair, we'll develop a briefing note to circulate to members of the committee on the back of that latest guidance and the support that we're providing to care homes, if that would be OK. That's
absolutely perfect. Thank you, Jane. Owen's nodding, so he must be in agreement. Thank you very much, Jane. We've got both Sue Jakes, and we've got Jennifer from Tees-Ascowee Valley. Sue?
Thank you, Chair. Just from a hospital perspective, we're currently in wave 2 of COVID. We've actually got more patients in hospital now than we had in wave 1, and we've consequently put restrictions on visiting, which limit visiting to really anyone that's just approaching end of life. It's critical that we do that to ensure that we can socially distance and we don't have any spread of COVID within hospitals. We keep it under continual review, and as and when the numbers reduce, we'll introduce a more normal type of visiting pattern. We do take inquiries from anybody who has any specific circumstances, and we'll look at those on an individual basis.
Thank you, Sue. And there was a reference there. I did comment, but not on your trust. My comment was regards to South Tees and North Tees, but you've all got a similar approach. Thank you very much, Sue. Jennifer?
Yeah, thanks, Chair. Just briefly, from a mental health perspective, from visiting, we in the first wave of COVID, we ceased visiting for a time, and that didn't actually fare our service users very well. So that in the second wave of COVID, because we don't have, unlike the acute trust, we don't have the amount of patients who are COVID positive within our hospitals, we are still allowing visiting to go ahead because it seemed to be detrimental for people's health and well-being if it doesn't. However, it's done on a purely risk-assessed basis, so we're going through quite a comprehensive risk assessment with both the patient and the visitors before that's allowed. We're encouraging visiting to be outside wherever possible, although acknowledging that the weather's not great at the moment for doing that. But we're certainly not allowing large volumes of visitors, and we're trying to make visitors book in appointments so we can stagger the amount of people we've got on site at any one time. So it's certainly we're not in a normal visiting situation, but we're trying to make sure that where visiting is important to people, especially people who've been in hospital for quite a while, that we're trying to allow that to continue if it's safe to do so. Thank you. That was me.
It was you. Thank you, Jennifer. Thank you very much. So there's nobody else either hand up or wishing to speak, so we'll move on. The next item, item 4, declaration of interest. Do we have any? Do we have anything from either Health Watch or Rosemary? Hello, Rosemary. Nice to see you again. Anything from either Rosemary or Health Watch?
No, thanks.
Thank you very much. We then now move on to item 6. Good morning, Lee. Can I ask Lee to join us, or are you going first, Jane, to introduce, and then Lee, or are we straight to Lee?
Thank you, Chair. If I could just say a couple of words before Lee comes in, if that's okay. And I know at the meeting in July, members were really keen to have further discussions around social care and understand the kind of complexity and diversity across social care. And there is obviously a very detailed report in the papers for today's meeting that goes through the broad range of the kind of legal framework, how we operate and the types of support we provide. I'm just going to hand over to Lee, Chair, if that's okay, because we thought it might be helpful to just pull a few slides from that, but also some case studies to be more illustrative, really, of the kind of challenges and the kind of support that the services provide. So if that's okay, Chair, I'll hand over to Lee.
Thank you very much, Jen. So good morning, Lee. We're all yours, sir.
Good morning. Good morning, everybody. Can everybody see the slides on their screen? First off.
Well, I can certainly see them, and I'm getting nods, yes. So far, so good, Lee.
Okay, that's a good start then. I'll take you through the slide deck, and obviously I'm happy to take any questions, and I'm sure other officers are happy to take questions at the end. So rather than just slavishly go through the report that everybody's had, we've produced a slide deck, and as Jane said, we're going to focus on a few case studies, which hopefully helps to bring my world, the world of social care, to life. As you can see on this particular slide, we're quite a heavily regulated service. There's lots of governance surrounds us, lots of regulations, standards and legislation, and many of the directives and the guidance that we are subject to comes from the organisations that you can actually see on that screen. In addition to that, we have organisations such as the Association of Directors of Adult Social Services, the Local Government Association, and the Social Care Institute for Excellence. It's also worth pointing out at a professional level, we also have bodies such as the Health and Care Professionals Council and Social Work England, and they regulate our occupational therapists and our social workers respectively. This slide gives you just an illustration of some of the main pieces of legislature that we work to. Care Act is probably the one that most people are most familiar with, that we obviously use every day, closely followed by the Mental Capacity Act, then the Mental Health Act. The Human Rights Act's on there because that can be described as a form of superior legislation. So every other piece of legislation that we work to has to comply with the key principles associated with the Human Rights Act. We have, as I'm sure everybody is already aware, we have really strong partnership arrangements in Durham, and the organisations that are illustrated on this slide together work to form the County Durham Care Partnership. In addition to that, I think it's fair to say that we do have lots of other partnership arrangements with obviously the likes of the voluntary and independent sector. You'll have noted that within the report, we have, I think, around 300 contracts with different organisations linked to adult social care. We also have very close working relationships with the likes of the police, fire rescue, prisons, probation, and obviously within the council we have a number of internal partnerships with the likes of the children and young people services, the likes of housing, as well as environmental health and consumer protection. As you can see, we support a large number of vulnerable people at any one time, and this slide just gives you a list of the types of presentations effectively that we work with on a day-to-day basis. So it's not just frail elderly, as some people associate us with. We also work with lots of other people too, and it's probably worthwhile pointing out that, as referenced in the report, that we apply a nationally applied eligibility criteria to, and that actually supports our professionals to determine the thresholds for those who are eligible for accessing council-funded services. Statutorily, goes without saying, we support some of the most vulnerable people in our communities. In terms of direct ongoing social care provision, you can see there's about 8,500 people who receive such provision. 65% of those are people who live in their own homes in the local community, and 35% are people who are resident in residential care. The philosophy that we work to is enshrined within legislation and guidance, and it's there to support people to live in the community as long as they possibly can, as independently as possible. So it's very clear that 24-hour care provision is the last resort. That just gives you a very broad overview of how we're actually structured. And you can see on those slides the staffing numbers that we have, including the large number of staff that I have under me within my service area. Within the report, you were also given some information in terms of the budgets that we actually manage. So in totality, we manage a collective budget of about £313 million. Within my side of the business, that equates to £213 million. And that pays, obviously, in addition to staffing, the likes of domiciliary care, residential care, day services, to mention some of the main ones. In addition to that, Commissioner have an additional budget of about £16 million, which is used to fund some of our generic services. Think about some of the services that we fund through the likes of the voluntary sector as an example. Then obviously we've got a public health grant, approximately £56 million. And there's a bit of a shortfall from those numbers if anybody was watching or listening carefully. We have approximately £27.5 million on top of that for central funding. A large portion of that helps us to fund integrated services through the Better Care Fund. You could categorise the way that we provide our services in three tiers effectively. We start with a front of house who deal with all inquiries that come into social services or adult social care in the first instance, and they work to set of principles that involve resolution, signposting and onward referral. In relation to social care direct, briefly, it contains social work staff, occupational therapists who oversee and work with a number of unqualified staff. If you think about the social and social care direct, they deal with a wide range of things, from the likes of social isolation to sensory support, and also the likes of safeguarding inquiries. Think of the C in social care direct, and you can think about things like carer support, the Care Act, Care Act assessments, providing advice in relation to interfaces with continuing healthcare. And you think about the D, and you range it from things such as your direct payments, day services, to disability-related issues, just to give some kind of illustration. For those people who then go on to receive intervention, we start typically with short-term interventions, which are aimed to maximise independence, and we use principles and processes associated with the likes of reablement, support and recovery, and rehabilitation. Once we work with people to maximise their potential, if you like, those people who still require ongoing care and support will then move into long-term services, and we have a number of long-term teams across older people, learning disabilities, mental health services that will support people long-term, as I say, to maintain independence, protect quality of life, and to help people to remain in the community, in their own home, wherever possible, for as long as is possible. What I thought would be helpful to move on to, like I say, just to bring the report to life, really, is a couple of case studies. They are fictitious, but they are very typical, I would say, of the sort of work that my staff will deal with on a day-to-day basis. So we'll start with Anne, an older lady with age-related frailty. So Anne first comes to the attention of the service as a result of sustaining a fall and fracturing her wrist. She's admitted to hospital, discharged home with reablement, and visits take place 3 times a day. She eventually regains independence, no further care required, so becomes no further action as far as the service is concerned. And as things progress with Anne, she develops a urine infection and becomes confused. So we have the likes of the GP, district nurse, social worker working together, and there's an arrangement made for a continence assessment, antibiotics, and a further period of reablement. Sadly, her confusion worsens and the GP refers her to mental health services for older people, and a consultant diagnoses that she has early onset dementia. At the end of the reablement process, she still has ongoing needs, and help is provided on an ongoing basis with the likes of meal provision, medication, some low-level personal care, and we therefore have to commission a longer-term care package. The dementia gets worse. She begins to wander. She wanders outdoors during the night. There's a telecare door sensor fitted by Care Connect to respond to overnight incidents, and the care visits end up being increased to 4 times per day. Subsequently, there's multiple reports received by the likes of the police and neighbours about Anne's dishevelled appearance, clear and progressive deterioration. She's exhibiting aggression and bizarre behaviours, and she starts to attend a dementia day centre once a week as a consequence. Multi-agency meeting takes place involving a range of professionals. Neighbours have reported feeling harassed. Fire service have had to attend because there's been 2 small fires within the household where Anne's left the pan on the hob. She's sustained 2 further falls, and dementia is clearly getting worse. Anne is no longer deemed to have the mental capacity to make decisions about her own care or where she should live. So a social worker uses the Mental Capacity Act to make decisions in her best interests, and she subsequently moves into a care home that provides specialist dementia care. The local authority authorises deprivation of liberty safeguards under the Mental Health Act, which effectively helps to uphold Anne's human rights within care, given that she's not able to make her own determinations. She doesn't settle very well in the care home, unfortunately, and she objects to having to live there, and she regularly tries to abscond. So the social worker and the adult services legal staff refer the case to the Court of Protection, where a judge ultimately has to make a determination about Anne and where she should live on a permanent basis. So that's the first one. The second one is a gentleman called Tom, who has a learning disability, and he lives with his mum. Now, his mum's 75-year-old, and she's been his main carer all of his life. She's becoming increasingly frail and can't do as much for Tom as she used to. Tom doesn't understand this, and his behaviours are becoming more difficult to manage. So, social worker assesses Tom's needs, and also mum's needs as a carer under the Care Act. Mum is referred to a local carer centre for psychological support, and Tom starts attending a day centre to give his mum a break and to increase his social interaction and opportunities involving other people. Mum becomes ill and needs an operation in hospital, so the social worker liaises with the GP, who talks to the hospital consultant about planning an operation date around Tom's care arrangements. After a review, it's agreed that Tom will stay in the shared lives provider. Now, shared lives is the adult equivalent of foster care, whilst mum's in hospital, and he'll continue to go to day centre where staff who know him can monitor any changes in his behaviour. Mum develops further complications after operation, so the placement for Tom has to be extended. Mum eventually does come home from hospital with a care package in her own right while she recuperates, and the care staff who will provide care and support to Mum also help Tom, but unfortunately he won't let them do much. So after a review, it's agreed that a family friend will be employed via a direct payment to provide care and support to both Tom and his mum. So that's offering familiarity to Tom and his mum, somebody that they both know and trust. And training is provided via our care academy to make sure that person has all the prerequisite skills. Mum's health deteriorates and she now needs end-of-life care. So Tom's referred on to an independent advocate, somebody who can act on his behalf in his best interests and help decisions to be made fairly and appropriately and proportionately and involving Tom as much as possible. After a review, it's agreed that Tom will move into supported living, where he'll share a house with 3 other adults with similar needs associated with learning disability. He's supported by staff to develop some independent living skills. He continues to attend the day centre, where he's made some good friendships and learns how to cook. So there you go. That's Tom. Okay, just moving on then in terms of transformation. Hopefully you'll have got within the report a flavour of the changing environment that adult care, not just adult care, other parts of the sector are subjected to. So we've had 10 years or thereabouts of austerity now. We've been progressively developing our integration agenda over that period of time. During that time as well, we've seen a rise in demand for our services. We've seen a lot more people with more complex presentations. So the nature of the work that we undertake has become much more intensive as a result. There's been significant technological advances over the last few years, let alone the last 10 years, and the pace of change is quite phenomenal. So our adult care transformation programme has been required effectively to keep us ahead of the game. And you can see on that slide some of the principles associated with that. In terms of challenges, mental health is a key challenge at the moment, and many of you will be aware that during lifetime, 1 in 4 of us will be affected by mental health. There's been an increase in suicide rates nationally, and also the national loneliness pandemic appears to be something which is gaining recognition. Social isolation, loneliness and mental illness are more prevalent amongst adults with social care needs. And thinking about that logically, that's perhaps unsurprising. Mental health services are seeing a lot more people than they've seen before during the last 6 months, and the presentation of those people I think is changing. So rather what I should have said, they're seeing a lot of people who they haven't actually seen before. In terms of hospital discharge, there's a new policy in place where we're actually moving increasingly towards and progressively towards a discharge to assess model using trusted assessment. In terms of transforming care, that's about learning disabilities, people with complex needs who have been in long stay hospitals, and increasingly there is much more work undertaken to enable people with complex learning disabilities to live in their own homes in local communities. We've been anticipating a forthcoming green paper for quite some time now. That's obviously been delayed in relation to COVID, and part of the rationale behind that paper was to try and find a different and sustainable way to fund adult social care for the foreseeable future. I've already mentioned integration with the NHS. Very key are our partnerships in County Durham, and partnership working is really strong, as I'm sure you're probably all aware. And in the context of austerity and growing needs, it's extremely challenging, but we are constantly working on how we can make the most of our finite collective resources. So in terms of legislation changes around us quite frequently. There's a new piece of legislation called Liberty Protection Safeguards that, as things stand today, are likely to be implemented in March 2022. And that will update our approach to mental capacity and in relation to people who are deprived of their liberty. So, like I say, an awful lot of things that are going on around us that effectively require us to continually reform and update and develop the way that we actually work in social care. So that, I believe, takes us to the end of the presentation. Obviously, myself and officers who are here, more than happy to take any questions.
Thank you very much, Lee. We have two councillors at the moment, Councillor Tanya Tucker and Councillor Liz Brown, who both registered to speak while you were speaking. So we'll take them first. Tanya, would you like to go first?
Thank you, Chair. Lee, thank you for a comprehensive report. You've touched on quite a lot about residents with changing needs and becoming more complex. I'm just wondering, with the current climate, how quickly CHC assessments are being carried out if clients develop a primary healthcare need, and also if there's a backlog in assessments. I'm conscious that if a client does develop a primary healthcare need, it may be that the DCC isn't responsible for their funding. So I'm just looking to see, are there delays? What is the timeline for actually getting the assessment? And are health providing funding in the short-term basis prior to the assessment being carried out as a way of mitigating some of the costs?
Sure.
Thank you.
Before you answer that, Lee, to get myself out of bother, Councillor Richard Bell actually registered to speak before Tanya, so if we get Richard in and you answer both together, I'm hopefully out of bother from Richard. Richard?
Sorry.
It's not your fault, Tanya, it was me. I missed Richard off. Thank you, Richard.
Thanks, Chair. I'm happy to come in any time, so don't feel you have to break Tanya off midstream. But my points were a little bit different, actually. Firstly, I just had a question on paragraph 19 of the report, the adult social care staff numbers of 955. Could you just tell us sort of briefly what the main distribution of them is? Is that mainly people caring for folks at home, or what's the sort of breakdown of that? That's quite a sizable number.
Yeah.
Secondly, just in terms of COVID and discharges, etc., while I'm certainly clear this report, which I must, compliment you, it's a good comprehensive overview of the social care system, while it certainly wasn't intended to be focused entirely on COVID and discharges out into the community and homes, back in July when we discussed this, it was certainly intended to be covered. And I think my precise words at the time were that we need to look at the social care system in the context, particularly of COVID. And given that a lot of us have had quite a few emails in the last few weeks from people concerned about how we're going to do things differently this time round, and discharges into homes and into the community this time round from COVID, I do feel that that is an omission, that we haven't looked at that at all, and I don't know whether we're able to answer that to some extent today, Lee, or whether we need another report specifically on the response to COVID. But I do feel that while I welcome this as a very good comprehensive overview of the system, given what the climate is out there, it would be remiss of us not to pick that up. Thanks, Chair.
Thank you, Richard. So you've got two there, Lee. You've got Richard's question and you've got Tanya's. Thank you.
Okay, I'll start with the staffing one first, I think, if that's okay. So in general terms, you could categorise those staff into two distinct areas. We have our frontline staff, which is made up of like the social work assistants, occupational therapists, team managers. So we have, as an example of that, we have 5 locality older persons teams within Durham. Each of those teams will have between about 25 to 30 members of staff within them. Similar arrangements within learning disabilities and within mental health. Hospital discharge teams, typically made up of a range of frontline professionals who undertake assessments of need, risk assessment and commission services to meet needs, as well as providing ongoing professional support and engagement with a plethora of agencies. So I think I've mentioned within the presentation. The other side of that, the service is our in-house provider staff. So we have staff working providing direct care and support within the likes of extra care. We have a respite bike unit for adults with a learning disability called Hawthorne House. We have day services still. We have a support and recovery service, and we provide shared live services, which I mentioned earlier. It's kind of a form of adult foster care. That, broadly speaking, Richard, makes up the adult sort of care workforce. In addition, we obviously have other sort of staff who provide us with backroom functions, if you like, in relation to performance and various other things. Can I go on to the issue around delays, and I'll come on to the COVID issue last, if that's okay. So in relation to assessments, in terms of CHC specifically, effectively, as a result of COVID and the height of the pandemic and up until September, the rules changed. So on one hand, you could argue, yes, there's a backlog of CHC assessments, but what we had in place was an arrangement that people who effectively were coming out of the hospital, typically those people who would be screened for CHC, those service users or patients, whichever term you prefer, received services to meet their needs that were fully funded through the NHS via CCGs, and that continues to be the case. Within that caseload, there is a number of people who have had checklists in relation to CHC, and therefore, because of those several months, there's a backlog. We're currently working through that backlog at the moment with our colleagues who oversee the CHC function, work on behalf of NECS, North East Commissioning Service, and we're working through that in a systematic way, effectively. It may take us until near the end of the financial year to do so, but until we've actually done that, those people continue to receive their service funded through the NHS. So hopefully that provides some assurance there that there's nobody kind of paying for service needlessly. In terms of, from a social care perspective, we've managed to keep on top of the workload effectively throughout the pandemic. We've never stood down. We've been business as usual. Yes, we've had some challenges in relation to undertaking some of that work remotely, but we've got a dynamic sort of risk process in place. If we've had to continue to assess people face to face, then of course we would do so. Good example of that would be the work of our AMPs, who are adult mental health practitioners. They're the people who effectively undertake assessments that result in people being sectioned under the Mental Health Act. All of their assessment work has to take place face to face using full PPE. Hopefully that answers your question.
Thank you, Lee. It does, yes.
Back to Richard then. Obviously, we've had to work differently as a consequence of COVID. When we last came into overview and scrutiny, we did obviously try to provide an update at that point in relation to how we'd responded to COVID. The reality is that the guidance surrounding us has changed at pace, and it continues to change. What we do with our system partners in Durham is that we continue to react and respond to the changing guidance. That guidance, in effect, if you think about it, reflects national learning, and we've done that every step of the way. Effectively, we've done it very quickly, and we've done it very proactively. We continue to do that, and obviously we're a reflective set of professionals, reflective organisation, and we do undertake exercises which Jane might want to kind of come in on in relation to learning at key points in terms of how we can continue to progress and develop. Don't know if Jane wants to come in, or Sarah's got a hand up, I think.
Yeah, Lee, we've got Sarah that's got a hand up. So Sarah, would you like to come in and answer any of the two members' questions?
Thank you, John. It was just really to add to some of the comments that Lee had made around CHC. I think our integrated working and our partnerships in Durham have meant that for a long time we have a very pragmatic approach to CHC and funding, and one that puts people first rather than the individual financial rules for each organisation. Many of the CHC staff had been redeployed to work in frontline clinical roles, and some of them in the hospital during the first outbreak, but we have recruited additional staff to help to address that backlog of CHC cases. But what it meant, because staff were working in a very different way during COVID, it meant that we got to try things that perhaps we wouldn't have been able to try and test different ways of working. And at the moment, we're looking at what was good and what we would want to retain, because some of the ways that we changed our working are things that actually made things better for patients and for families. And perhaps my colleague Michael Leng, who is looking at the discharge processes going forward, might be able to add some of the detail around how we're approaching that.
Thank you, Sarah. Thank you, Lee. OK, Liz, before we come on to your question, I won't forget just to remind people, if you look in the meeting chat, we've got a comment from Jane Stunt in regards to suicide and clarifying that. So thank you, Jane. So at the moment, we've got Councillor Liz Brown, and then Councillor Owen Temple. Liz, I can't see you on my screen, but you're there somewhere. I know you are.
I'm there, Chair. Thank you very much. Councillor Liz Brown, Neville's Cross. Thank you very much for your presentation, Lee. You've touched on something that I feel very strongly about. Page 54, Tom, who may be fictitious, but as you know, I worked with adults with learning disabilities in a previous life, and a lot of them also had mental health problems. This may be a fictitious story, but I've seen it 2 or 3 times. I'm looking and I'm thinking a lot of what you've done is reactive. Is there anything that you're doing proactively to help these people? Because it does happen so many times, and it's very, very upsetting when it does happen for all concerned. Thank you.
Yeah, I'll answer that.
Thank you, Liz. And then, Lee, if we take Owen's, then you've got 2, because they're the only 2 who actually asked to speak to you at the moment. Owen?
Thank you, Chair. And Lee, can I also add my thanks to for your report, which I thought was very wide-ranging, communicated very well with us the kind of breadth of what has to be covered. It was really useful for this committee because I don't think we've had enough sight of the social care aspects of our work. And I thought that your case studies were really, really helpful to me for bringing to life that range of things. So what I say now, I want you to see as no criticism of yourself or of the officers who produced this report. But I have to say that Richard probably said it better than I can. I am deeply, deeply disappointed with the report we have not got today. Because when in July I called for a report into adult social care, I did ask for it to have I asked for us to have I think the words were a specific and dedicated approach to how social care has fared in the first 6 months of this year. It was very definitely a request for a COVID-related report. And so I'm not in any way criticising you for your report, which isn't, but I am very unhappy about the fact that we are not achieving here what has been achieved in Scotland, just north of us, where they've done a report into hospital discharges, they've done a report into deaths from COVID, and they've come up with some conclusions, some statistically based conclusions. I was fascinated because they don't support my prejudices, but they might help to inform decisions, which is what we should be about. So what they discovered was that hospital discharge is associated with an increased risk of an outbreak when considered on its own, but they then said the estimated risk of outbreak was reduced and not statistically significant after accounting for care home size. They go on to say how hugely important care home size is in the number of deaths that have occurred, and it's the sense of an organisation which is looking hard at statistics and facts and then saying, what are we learning? How can we do better? Which has been everything that I've really been wanting this committee to be involved with. So my question really isn't for the officers, John, I'm afraid. It's more for yourself. What as a committee do we have to do to get that sense that we as a scrutiny committee are looking at the factual, statistical evidence and making judgments based on that? We live in a county with one of the finest universities in the world. It's got statistical capacity oozing from it. Why aren't we using people to look at what we're doing? No criticism, not at all, but about learning, because it isn't enough for us to learn internally. Organisations need to do what the Scottish Government's done and ask an external organisation to come and look at it and advise it. So, Chair, the question, I'm afraid, is not really for the officers, but for you. What do we, what does Richard, who spoke so well at the beginning, have to do to achieve that?
If we get Liz's answer, then I will answer myself as well, no problem one. But can we give the answer to Liz, Lee?
Yeah, I'm more than happy to do that. I understand, I think, where you're coming from, Liz, and it's a really difficult balance. What I would say is that much of the work of my workforce is proactive from the point where we begin to engage with our service users and those people who support them, i.e. we develop relationships with them. There's always a very fine balance of risk here as well, because obviously the philosophy behind what we do is about maximising an individual's independence, upholding their rights. There are often difficult dynamics, I think, within households as well, whereby wider people within families are impacted upon as a result of, ill health, deteriorating sort of circumstances with people who have got dependency needs. However, those individuals themselves have got rights, and we tread that balance every day, I would say. And the premise behind what we do, obviously, is providing services and support that don't create a dependency, enabling people to take the risks that they would wish to take. And obviously, if those risks become beyond sort of what you find in acceptable boundaries, where you've got safeguarding concerns, or if the person lacks capacity, then obviously we have powers, if you like, to intervene in those circumstances. So it's a difficult balance, but I would like to think that we do work proactively with people every day. Does that answer your question?
Thank you, Lee. It's just what I've got to be in my bonnet about this, because it happens so often, and I don't think anyone is ever prepared for it. And it always seems to come as a dreadful shock to everybody. And I mean, what do you do? As you say, it's a very, very difficult line to walk. But thank you very much for your answer.
More than happy to have a further conversation with you at some point if you would like that.
And in response to your question, Owen, I've never ever heard the Scottish report. So if you could forward that Scottish report, and I was watching Jane Robinson writing frantically, I would welcome that. Owen, I've gone through and watched the videos on live on YouTube, and obviously everybody's read the minutes, and certainly I can't find a direct request for a meeting, an inquiry. I've seen requests for discussions, etc. So the first I found was when we had the references lately. I honestly believe, and personally believe, Owen, at this time, having had a relative who died in hospital, that to look at care homes, to look at hospitals, to pick off individual services would be wrong. I believe at this moment in time, they are doing a job. It's the second wave. I actually believe it is a national issue. I believe it's something that should be looked at on a national basis. I think we need to look at the care home situation nationally, not just in isolation here in Durham, because there are different anomalies across the country. I also feel that we should be looking at deaths in hospitals, Owen. And you know that I'm saying that on a personal basis, and perhaps I shouldn't be saying it. I personally believe every single death, no matter where it's been, no matter what, is important and should be looked at. And I believe it's something that the government should be doing nationally. Once we have a national perspective, once we have a national approach, then I personally will stand next to you side by side and look at a local perspective. But until I know what's happened nationally, what decisions have been made nationally that is affecting the hospital, affecting social care, I honestly think it would be unfair. And secondly, I fully support and believe that it's at the moment in time, it's wrong to start looking at what we've done, not done. I think we should let the professionals get on and do the job and look at the second wave, and God, please, not a third wave. So I hope that answers your question, Owen. I can see where you're coming from, but I believe at this moment in time, we need to wait until we get national guidance. I've got Jane Robinson wanting to come in, and I've got Rob Crute. Jane?
Thank you, Chair. And it was just to kind of echo the point really around the Scottish report. And Councillor Temple, if you'd be happy to share that with me, we can certainly look at that. It's not something that immediately I'm familiar with. So if you could share that, that would be very helpful.
Thank you, Jane. Rob, Chair of the Overview Scrutiny Management Board.
Thanks, Chair. You've already said it for us. I was pretty much going to say what you've just said and underscore what Jane's just said as well. I wasn't aware of the Scottish report, but from what Owen seems to be saying, it appears to be a national report, and I think that's the way forward. So if we can have a look at that, and I agree with you, I think if the national government is to hold a report, then we should take every opportunity to participate in that. But until that point, then I think we need to see what's coming out of Scotland, and then wait and see what happens at the end of this pandemic. I know that there have been calls from other authorities up and down the country. The vast majority of them, in fact almost all of them, are calling for exactly the same as you've just mentioned, as well as James just mentioned as well, is for a national review at the appropriate time. And by the appropriate time, they mean when this pandemic's over, the dust settled, and we know where we're coming from. So 2 points, Chair, I think you're dead right. Let's have a look at this report from Scotland, and it appears from what Owen's saying that the national approach appears to be the best one, if it's right what Owen's saying, and then from that put pressure on national government for a review as well. And I strongly recommend that we participate in that review as and when it comes.
Thank you, Rob. Richard?
Thanks, Chair. Yeah, since we're going national, Lee mentioned in his response that the service had continued to react to changes in guidance at national level. So I just wondered, can someone give us just a brief summary as to where we are in terms of discharges from hospitals to care homes and to private residences? So is every care home, for instance, expected to take hospital discharges? Are we confining it to 2 or 3 specially designated COVID care homes? What's the current sort of state of play, please, in terms of the process? Thanks.
Owen, I know you want to come in, but Jane Robinson straight away was when Richard spoke. So if you don't mind, can I get an answer for Richard?
Thank you, Chair. And it's probably helpful if it's okay to bring both Sarah Burns and Michael Lang in at this point, just in terms of the Sarah's probably well placed to update in terms of the designated care setting, and Michael in terms of the discharge arrangements, if that's okay, Chair.
With the greatest of pleasure. If we want to get the answer, don't we? Sarah?
Thank you, Chair. So in during September and October, new guidance was published by the government about identifying what they have named as designated settings. And these are units within care homes that they have their own exits, entrances, dedicated staffing, have to meet stringent physical requirements, and that all people that are a care home resident and are fit to be discharged from hospital must be discharged to these dedicated settings. We have been working with care home providers across County Durham to identify those that have both the physical layout and staffing required to meet the national requirements for these designated settings. And at this point, we have identified one facility for nursing, patients that require nursing care. And we are in discussions about a residential unit in the county. Those units have to be inspected by the Care Quality Commission to ensure that they meet those requirements. And we have developed our own robust local assurance process, an enhanced partnership working that would take place between ourselves, and when I say ourselves, I mean the council, the CCG and the providers, to make sure that they are supported to deliver a safe service for people. We are one of the few areas in the country that have managed to get these agreements in place. There is a lack of capacity or a range of other issues that are preventing other local authorities to get these arrangements in place, but we are fortunate enough that we have providers that are willing to work with us in partnership to develop services for these very vulnerable people. If I pass over to my colleague Michael Lang, he can add the bit about the discharge from hospital and that process, because that tells you about the setting that people will be discharged to. But Michael and colleagues within the hospital have been looking at that discharge process and making it as safe and robust as it can be.
Thank you, Sarah. Good morning, Michael. Welcome.
Good morning, Chair. Thank you. And in response to Councillor Bell, we had new guidance about hospital discharge, which came out in July. What that did was set 6 weeks care for people being discharged from hospital that we weren't charging for, with a strong emphasis on people being discharged from hospital. So no discharges being delayed waiting for an assessment, and that's the discharge to assess part, and partners working together to allow staff to carry out what are called trusted assessments. So community staff carrying out initial assessments for social care, for example. We formed a working group in the County Durham and Darlington system, which involves partners from health and social care and the CCG. We're taking a two-step approach to that. The first step is to make as many improvements in process as we possibly can, and that builds on some of the work that the Hospital Trust has been doing, Chair, with their clinical discharge processes and speeding up discharge. The new guidance that came out in July gave some quite stretching targets to all of us, including getting people out of an acute hospital setting within hours of being identified for discharge, and that brings in all kinds of complications with transport and pharmacy. And the emphasis, as Sarah has said, is discharging people safely to clinically appropriate settings, which is why we've also used community hospitals, and this week increased capacity in community hospitals. So we aren't forgetting about using community hospitals for transfers of care for people who are COVID positive. Longer term, what the guidance expects us to do is to build on the good relationships that we already have in County Durham, and to identify single coordinators for the discharge process, so that will smooth out any glitches that we find of transfers of care of a patient between organisations, and we are well on the way to do that, Chair. So there are some practical improvements being made, which are reducing duplication, reducing the need for patients to tell their story more than once, and to get people out of hospital to a safe setting, a very safe setting, and that's the driving issue as quickly as possible, Chair.
Thank you, Michael, and I apologise, that was my form.
Thanks, Ed. That was very helpful, and I'm pleased to see community hospitals getting a mention in there as well. Thank you.
I was hoping he was going to say the Richardson Hospital. Owen, you have the right to come back.
Yeah, Chair, thank you. And in a sense, what we've just started to learn in the last 5 minutes is very closely related to what I wanted us to be learning from this meeting about what we are doing, but it doesn't change the need to reflect on what has happened and to statistically analyse it. I will forward the report, as you and Rob and Jane have all asked me to do, but it remains intensely frustrating because you yourself talked about different anomalies by region, that we aren't looking locally as well as nationally, and I completely agree with the need for a national review, totally agree with it. And I will stand side by side with you, John, but I am so frustrated at the moment that
Owen, please stop. We've lost you. Owen, please stop.
Sorry.
We need to go.
I don't know what's happened to my.
The last we heard was you say you were frustrated.
Right. Well, I am frustrated, Chair, and it feels to me as though we still need to be doing something locally to look at the different anomalies by region, as well as passing things nationally. Now, I am in constant correspondence, poor Jane, with her, and that will continue. And I am looking for some information, which I know she said she will get back to me within a few days. And I'll perhaps, Jane, you could copy that to John as well when you get it. Thank you.
Thank you. And Owen, I actually went on I'm about to say that I might have done the wrong one and looked at the wrong one, but I actually went on the parliamentary website for where people put petitions to petition Parliament, and I specifically looked for the one for the national inquiry, and there was 1,045 signatures. I won't tell you how many thousands of signatures there were on for banning Trump from the country. I could only find 1,045 for calling for a national lockdown and the national inquiry. And that's where I honestly believe we should be starting. But thank you very much for the approach you took, Owen. That we could have been in an argument there, and we weren't. We all focusing on the right thing. Lee, can I just say, I know Jane wants to come in. Owen said what I was about to say. There's an old saying, hasta la vista, I'll be back. We look forward to you coming back. Your service is very important to us, and the fact that we've learned that you carry 955 people who work with you proves that we need to keep in touch with you. So Lee, thank you very much, and on behalf of all of us, pass on to every single person who works with you and for you our health support and our wish that they all remain safe. Thank you, Lee. Jane?
My pleasure, Chair, I will do.
Thank you, Chair, and thanks to the committee as well for their interest in social care, and hopefully what Lee's presented this morning in the report just gives you that greater understanding in terms of the breadth and diversity. So thank you for your comments, Chair. If it's OK, I just wanted to kind of come back and say, yes, Owen, the information that I'm pulling together for you, absolutely will share that with John. That's not an issue at all. And I suppose it's just a final point really in terms of assurance, and Lee touched on this, I think, in his presentation, that as a group of professionals, we constantly challenge ourselves and understand how can we do things better, how can we improve, how can we learn from our experiences that are happening in other areas and nationally. So it was just to kind of give that reassurance that we are absolutely not complacent in any of this. And our key priority is to do the absolute best that we can to safeguard our local community. So I just wanted to end on that point, Chair, if that's OK.
Thank you, Jane. We represent 600,000 people, and that's the most important. Thank you very much. Can we now move on to item 7, winter planning, and welcome Sue Jakes. Welcome, Sue. You've sat there quite nicely and quietly. We're all yours, Mum.
Thank you, Chair. So I have the pleasure with Stuart Findlay of chairing something called the Local Area Delivery Board, and that board's responsible for ensuring that as a system we have a plan across that system to protect services over winter that's got robust oversight and escalation, and this report is to update you on that and hopefully provide you with that assurance. The plan is built on very strong individual plans of the constituent organisations with a view to restoring any services that were paused in wave 1 of COVID, and I can confirm that they have all been restarted, managing winter pressures and second and subsequent waves of COVID should we see them. And I described earlier that we are, as you'll all be aware, in the middle of the second wave of COVID, and that also we're able to deal with any local outbreaks. It uses a consistent arrangement for escalation across all agencies. So we use something called the OPAL framework so that at a glance we can understand exactly where pressure points are within the system, and we can respond to those with escalation arrangements which run daily. As we continue to be in a national major incident, our plan is consistent with and forms a key major plank of the work of the Local Resilience Forum, which you'll be aware runs across Durham and Darlington. It is a dynamic plan, and as we've already discussed, new advice based on research is coming out all of the time, and as and when that arrives, our plans are updated in accordance with that advice and guidance. It incorporates things wider than just our patch, things that are happening in the region. So initiatives such as the increased testing that will, by March of this year, see 80,000 more COVID tests being able to be undertaken in the region each day. An initiative that rolled out a couple of weeks ago called Talk Before You Walk, which is about informing the public about the best way to take advice before accessing emergency and urgent care services, and includes the Nightingale Hospital. The plan sits alongside and is complemented by the work of the Flu Board, the Health Protection Board in Durham, which is chaired by Amanda Healy, and the Strategic Command Group, which links to the LRF. That has been chaired by Terry Collins and is now chaired by John Hewitt. There is an urgent and emergency care network across the North East and North Cumbria, and that has reviewed these plans twice, once in early summer and once more latterly in summer. That board also reviews the plans of the whole patch for each of the geographies, so it is able to do some of that comparative work. And I can inform you that we have incorporated all of the recommendations of those reviews into the plans that we've got. In terms of the objectives, they're very simple. We are aiming to ensure that the system is able to effectively respond to winter and COVID-19 pressures, that we optimise all available system capacity, enhancing community services and primary care provision and support to care homes and nursing homes, that we have the highest standards of patient safety and patient experience, that we sustain the highest levels possible of performance in urgent and emergency care, similar to some of those that we experienced at the beginning of the pandemic when we saw our performance against 4-hour target increase, that we implement the hospital discharge service policy that we've already heard Michael, Sarah and colleagues speak about, that we minimise ambulance handover delays, that we enhance mental health support for patients and local populations, that we protect elective care as far as we're able to, recognising the pressures that the various waves of COVID place upon us, that we continue to provide essential support to all the key workers working across our agencies, that we encourage high levels of uptake for the flu vaccination this year, and that we maintain and enhance our COVID testing capacity. So if you've had opportunity to look across those plans, you'll see that the actions coalesce in 4 main areas. The first is optimising capacities. So that covers everything from the additional beds that Michael has referred to that we've stood up in the community hospitals, Today we stand another ward up in Bishop Auckland to cope with some of the extra demand that we've got. We've got our GPs primed to put hot clinics on to, if they're required, so that symptomatic patients can be seen in a COVID secure environment and enable other sites to see routine patients. We've embraced the Talk to Before You Walk initiative that began back on the 19th of October and is designed to get people as speedily as possible to the most appropriate level of emergency care. We've had and seen additional reablement packages procured. We've extended community services, and we've ensured that the tracker that we developed for care home capacity is now well embedded and allows us to have good oversight in terms of what's happening across the whole of the patch. The independent sector has played quite a key role in helping the hospital side of things stand up all the elective care, so care for patients who have been waiting some time for some of their operations. So we continue to work with the private sector in the patch. And we've been increasing the same day emergency care provisions within the hospital. So having patients that come in and where possible, we undertake all of the diagnostics, and if they can go home safely on the same day, they do. The second area is the optimising the flu vac for both the staff that work in our services and the residents of our population. We're doing very well on that and seem to be leading the way in terms of the regional response, which has been very robust when compared with the early results that are coming out nationally. The third area is ensuring that we do have the very most safe and appropriate discharge in line with the guidance that Michael has referred you to, and that patients and staff are appropriately cited on that guidance, and that is uniformly discharged. And then the fourth area is a range of support packages for both patients and for our staff, dealing with everything from mental health, supporting both our staff and patients in that regard, ensuring that our patients have access to a cancer services helpline, which was very valuable during wave one, and it's one of those points of learning that we've been discussing, and ensuring that our workforce can stay resilient at what is a very difficult time for them, with a range of different services and psychological support that they can access. In terms of this year, the plan is different because of COVID, and on page 5 of the report, I just raised some of the risks that we've acknowledged in developing the report and the response to winter this year, and can confirm to you that we've incorporated those into the plans. So we're expecting and indeed seeing increased levels of staff absence due to COVID test and trace, as well as that ordinarily presented due to seasonal flu. At the time of writing, we were anticipating we might have a second or third wave of COVID. I think as time has told, we're in the middle of that second wave. And as I described earlier, we've actually got more patients in hospital with COVID now than we ever did in wave 1. We know that there's an increased incidence of mental health that's arisen from both COVID itself and from the lockdown. And for patients that have had COVID, for some of them, they've got an incredibly long rehabilitation time. So we're needing to put different services in place to help them over months and what possibly will extend to years. We know that colleagues in the care home and nursing home sector, like the other sectors, experience issues around staffing linked directly to COVID, and we need to be ensuring that we're able to support them appropriately. We appreciate colleagues in the ambulance service who need to ensure that there's social distancing in the hospital transport services, and that can lead to various operational requirements that we need to compensate to ensure that we can get patients out in a timely manner. And we know that our bed capacity will be impacted on by various staff needing to isolate, by the way that we need to ensure that patients with COVID are separated from those patients without COVID. And indeed, we test everybody coming into the hospital. So until we have a test result, we can't let each patient really need near anybody else. So we're, as I've described, increasing our own testing capacity, and we do expect that we'll have a high volume analyzer that will come into play before Christmas. So we think we've developed the most optimal plan. We've developed it using the physical and workforce resources that are available to us to ensure that we can provide a safer provision of services as we can throughout winter. We've developed it iteratively and collaboratively. We've had it assessed and peer reviewed, and we have sufficient daily escalation arrangements in place such that we can modify and stand aspects of the plan up and down across the system as they're necessary. So I'd ask you to receive the report and to use it as assurance that we have indeed got a winter plan across the system in place that can cope with COVID this year, and that we have robust daily oversight of that. Thank you, Chair.
Well, thank you, Sue. And you seem to be carrying this torch year in, year out as chair of the winter planning. Every year I wish somebody else would step in and give you a breather, but no, you do it every year. Thank you very much, Sue. I've got Councillor Tucker. Tanya, you want to come in?
Yes, Chair. Just one quick question, Sue. Report was really comprehensive, and you've given us a verbal overview of it, which was really good. I'm not sure if my question's to you or one of your colleagues. I'm just wondering, the flu vaccination, how well across the county has the uptake of that been across staff and residents, given that there are a high number of residents who may well not be able to go out who, for various reasons, and may need a flu jab? How across the county are we dealing with that for a preventative measure? Because you can plan for winter, and no amount of planning can provide for an escalation of whether it's winter flu or COVID symptoms. I'm just wondering if the uptake on the flu vaccination across the county has been as high as previous years, or if there's still a lot of people that we know should have had the vaccination but probably still haven't, if that makes sense.
It does.
Sue, should we just ask Rosemary, because Rosemary, as Tanya was talking about flu, jumped in. Is your question on flu as well, Rosemary? Rosemary, are you with us? We've lost her.
Can you hear me now? Can you hear me now?
Was your
no,
question?
it wasn't. It was just to say that we'd had cause to use Darlington A&E recently, and how impressed I was with the service made available. It was excellent.
Thank you, Rosemary. And I have to back that up, because my daughter went there with my granddaughter and came out and said it's the best hospital she's been to. Sue, Ananda, Sue?
Yeah, thank you about the comment regarding A&E at Darlington. I think one of the really innovative changes that we made both in Darlington and Durham in Wave 1 was to change the footprint of those areas. So they're actually both Darlington's probably slightly more than double its original size, and Durham is almost double its original size. And without that, we would be nowhere able to cope with Wave 2. And those changes were made overnight. So it's great when they have such a positive impact on patients that are using them. In terms of the flu vaccination, I'm happy to provide you with the most up-to-date information, Chair, for circulation after the meeting. What I can say now is that we, as a patch in terms of staff, or certainly last week, were the second highest in uptake across North East and North Cumbria, that we were at much higher levels than we were at the same point last year, that our GPs had mobilised to purchase the vaccine early and purchase additional vaccine, and there were various initiatives to incentivise them. So my understanding is that our uptake across the piece is better than the same period last year, but I'm happy to get the detail and send it to you, Chair, so that it can be circulated to the committee.
Thank you very much, Sue. Amanda?
Yeah, thank you, Chair. Amanda Healy, Director of Public Health. I think obviously just to back up what Sue said, I think we are finding that our uptake, I think because there's been some really innovative ways of working, of trying to reach people with flu vaccination, I think will actually be early signs are that it will be very high. Obviously, I think all of the measures that we put in place for COVID in terms of hand washing, people protecting themselves using face coverings will also help to stop transmission of flu. I think the one frustration that we have found is that there was a national stockpile and where we had hoped to extend some of our flu vaccination programme, we're wanting to do that for all of our staff groups across the council, for example. That hasn't been put in place as yet. However, we do understand now that GPs and pharmacies do have additional vaccine supplies for social care staff, which will include our domiciliary care staff, who are obviously a really key group that we want to ensure that they have their vaccination. So I hope that just adds, Chair, to what Sue's already said.
Thank you very much, Amanda. Sue, you've done very well. You've got nobody else who wants to speak. So I do apologise, Owen.
Thank you, Chair. It was actually only on the flu question to congratulate the people locally where I live, because it's not just me, but my friends who are all a bit old like me, who've had the vaccine. They just commented on how wonderfully efficient. It was brilliantly manned, and I have to say that there were more than one member of this committee was there greeting people and pointing them in the right direction. It was all hands to the pump. So congratulations to everyone who's been involved in it.
I think that's the first time in your life you've been a doorman, Councillor Temple. I take it you were one of them. Can we say thank you very much, Sue? Sue, we said thank you to all our staff, but clearly we need to say thank you to all of your staff. And also the fact that you've got more people in, send our best wishes if you can to every single person that's a patient there, that we are rooting for them and looking hopefully that they will come home. But Sue, no words can say what we owe the NHS and your trust. So thank you very much to you and everybody for what you're doing. Thank you very much.
Pass that on. Thank you.
We now move on to item 8, which is our Amanda and also Jane. Amanda, are you going first?
Yeah, thank you, Chair. And Chair, before I introduce Jane and the health impact assessment report, I thought it might just be just to give a very brief update on some of the work, that obviously the wider COVID-19 related work, because obviously things have moved on quite rapidly since our last scrutiny meeting in October. I think at that point we were in local restrictions, and we had continued at that point in time to have almost a weekly dialogue with officers of government. We were also managing within County Durham, our rates were increasing, but predominantly linked to quite a large student outbreak, which we are now seeing is very much under control and being contained, with a lot of close working with the university and with the students in relation to that. And we were also having weekly meetings with the Chief Medical Officer and Deputy Chief Medical Officer, and starting to see those rates in County Durham and the other local authorities in the LA7 starting to level off and to plateau. However, obviously what we have now found is that we are moved into the national restrictions, and I think, having listened to Sue and having seen our rates increase slightly over the last few days, I think obviously really hard though it is to be part of national restrictions and the limits that it places on obviously the mixing of households, the return for people to work from home, they are very challenging for families, that they will give us hopefully that opportunity in the next 4 weeks to see our rates go back in the right direction. We have done a lot of work with colleagues in the other local authorities and have agreed some key areas of focus, which are then reflected in our local outbreak plan, which include aiming to kind of localise at a regional level, test and trace, to really focus on those that are most vulnerable, including obviously the standing up of our community hub to support people who need to self-isolate or who are feeling lonely and need medication, or clinically extremely vulnerable, and obviously within care homes too. And a major programme in terms of community engagement and community champions. And this is very much about taking our communities with us. We're hearing a term called pandemic fatigue quite a lot, and ensuring that people feel that they are able to support the work and really understand the seriousness of the situation. And that is also a major piece of work. And then moving towards a kind of COVID vaccination programme. During the time between October and now, we're obviously managing outbreaks. We're in a series of outbreak control teams and working very closely with Public Health England. Obviously, the one I've mentioned there was the student outbreak, which is now coming very much under control. And we're very much working with colleagues, including adult social care, obviously like Jane as corporate director, to look at different forms of testing. Our current rates are at 322 per 100,000, and that's on average a 7-day average of 1,666 cases in County Durham, and we can see that, and that gets updated on that dashboard. And I think over the last month we have seen cases within our schools, but they tend to be very small numbers and managed well. We have obviously got almost 270 schools across County Durham. We have seen them in workplaces, and obviously with the shift in the restrictions, many places are now not able to operate. So we may see those rates come down even further. And we've seen some of those in workplaces and within some of the care settings as well. We have seen a slight increase in our 35 to 64s and our 65 plus, and obviously listening to Sue in relation to hospital admissions, that older population is where we see that admission to hospital. So we really want to take every opportunity in the next 4 weeks to make the impact, because of the wider impacts of a restriction. We want to be in a good position to come out on the 2nd of December and hopefully be able to open places up and return to some sense of normality, with rates getting lower. And so I hope that gives a brief update. And as ever, we do have the Health and Wellbeing Board later in the month, and there'll be an update, a more detailed update at the Health and Wellbeing Board, along with the local outbreak control plan and the community engagement and community champions. And as I mentioned earlier, Chair, the sessions with members on the data dashboard, and hopefully get those in the diary very soon. So in terms of the health impact assessment, this is a really important piece of work, and I'm delighted that Jane is able to present it today, and she will do a presentation rather than go through the report in detail. And it has really been to understand some of the health inequalities and consequences of COVID-19 and the impact that it's had. We know obviously the impact that it's had on individuals, families and our communities. And this work it's been a formal process. Health impact assessment is a particular process to look at how we make the most of any positive impacts and mitigate against any negative impacts from a particular policy. Jane will talk to us about some of the things that were excluded from the health impact assessment itself, but then most importantly will also draw us to the specific recommendations. Sue referenced mental health, and you will see in the report, and when Jane presents, the mental health implications of COVID-19 and how we must and seek to address those. And obviously, as a scrutiny committee, will then be able to hold us to account to implementing those recommendations. So, Chair, if it's okay, I'll hand over to Jane Sunter, who's Public Health Strategic Manager and who carried out this really comprehensive piece of work. Thank you.
Can we just check, Amanda? I'm more than happy to go straight to Jane, but Councillors Brown, Liz, you came in. Is it specifically a question to Amanda or the report in general?
Chair, it's more of a quick, irritable whinge that I don't think people are aware of. My husband is extremely clinically vulnerable. At 10 o'clock on Wednesday night, he was told he had to shield from 12 o'clock on the Wednesday night. It's despite the fact that the Prime Minister insisted, because of the mental health problems, that he wouldn't ask anyone to shield. I don't think very many people are aware of this, and I feel that they ought to be. I'm sorry, Amanda, I'm interrupting.
No, Councillor Brown, it's absolutely fine. The work with clinically extremely vulnerable had to be done very quickly because, as you say, the guidance only just came out last week. So we have re-established our County Durham Together, the community hub, and we have letters going out to all of those who are clinically extremely vulnerable first, and then within our wider population, any of those who may be vulnerable from the impact of the restrictions, just as we did last time. And there are some slight differences this time in terms of the clinically extremely vulnerable, which, although it's still restrictive, that there are still things that people who are clinically extremely vulnerable should be able to do in terms of, being able to get outdoors during the day and get some exercise, not mixing with others. But we've followed up as rapidly as we could. So certainly, your husband, Councillor Brown, should have a follow-up letter from us locally, obviously that's been put together with NHS colleagues as well, to say what's available to support, what we're able to do, and to give that support during this time, which I can appreciate is really challenging.
That's wonderful. Thank you, Amanda. I keep telling him he's very, very lucky to have me who knows what's going on, but I was very, very worried about the people who didn't know what was going on and suddenly got a text out of the blue on the Wednesday night. I mean, we just wait and see, but I think it's another case of last-minute-itis, which this government appears to be suffering from. Thanks,
you,
Amanda.
Thank you, Liz. Can we go
quiet
Jane
now?
Jane?
Lovely, thank you. I'm hoping that you can see the presentation. Has that come up for people?
It's there, Jane.
Brilliant, thank you. Okay, so thanks, Amanda. Thanks, Chair. Just to introduce myself to you, I'm a Public Health Strategic Manager in Amanda's team, and I oversee the Living and Ageing Well work stream, which is the adults of working age and also older people as well. But I think it's important to say that this health impact assessment was done right across the life course, so that also included younger people, children, young people as well, as part of the screening process. So I think it's important that we see this report, really, this health impact assessment, and it is a big report. It's 90 odd pages. So we thought we'd kind of bring you a presentation just to kind of summarise some of the key aspects of the report, recommendations and findings. And the report itself focused on not just the kind of the impacts on the virus, but more on the impacts of lockdown at the time. A health impact assessment usually takes 6 to 9 months, but I probably did this over 4 weekends right at the beginning of the pandemic to enable us to kind of have an audit trail for what we needed to take forward in our recovery response to COVID. But just to kind of, again, highlight the impact of COVID on our residents. But again, this evidence base is growing on a daily basis, I would say. But as we know, we have the impact of COVID itself has a higher impact on those of an older age due to vulnerabilities and long-term conditions. The virus has a higher impact on men, but actually lockdown has a higher impact on the mental health of women. We also have residents within certain geographical areas experience higher levels of impact, and that's due to inequalities. And again, this is the frame of the health impact assessment document itself. And within that are the key vulnerabilities around people within BAME communities, which for us in County Durham actually reflects on our Gypsy Roma traveller communities and requires further investigation. Obviously, everybody in this meeting will know the high impact on child poverty, educational attainment and future employment opportunities. And that's especially around young people as they start on the sort of the employment pathway, really. So A rapid health impact assessment was undertaken, and as Amanda says, it is a very technical piece of work that happens. It's very much around screening all of the areas that we think could have had an impact on inequalities during COVID, actually identifying those health and social care impacts, but also being able to then prioritise where we see those impacts having the most effect. We also analyse the data and from that make recommendations, which I'll come on to. So very much the process itself looks at what does the evidence tell us, what are the kind of priorities we're taking forward. And I have to say that even though this was done right at the beginning of the pandemic, there's so many crossovers as we move into our second phase of lockdown restrictions. It's very much around being able to predict in a way what the short-term, medium and long-term impacts will be of COVID as well. But as we know, this is an ever-changing piece of work. And again, it's very much around focusing on the strengths that we have within County Durham and also our areas for improvement. So as you can imagine, the number of issues that could impact inequalities across the county, we used it as an opportunity to kind of funnel down on some tangible priorities and managed to boil down through the screening process by looking at the policy documents, looking at the ways that people are working, to actually funnel that down into 4 areas. So they are around socio-economic impacts factors, especially around poverty reduction, around, as Amanda's already mentioned, mental health and emotional wellbeing, a real key area for our focus. But also being able to focus on the community assets and how we mobilise communities to help themselves as well, and actually signpost people and handhold people into local community and voluntary sector organisations, so that we kind of stop the stem of the demand on our statutory organisations as well. But then also kind of as an inclusion, a golden thread going through each one of these areas is actually the inclusion of vulnerable groups integrated into the key priorities. Again, as we mentioned, kind of through the BAME communities, but also multiple vulnerabilities. So looking at the 4 key priority areas that were identified through this process, that doesn't mean to say that other areas were not identified as being key to the way that we all need to look at our impacts in everyday policies and work in practice. That work certainly was around what the impact was on education and skills of our children and young people, included within that the university students and college students. Also looking at the impact on housing and homelessness, criminal justice being part of that as well, domestic abuse, another key area of focus, in the mix with that also safeguarding as an underpinning feature. Our impact on, as we've already talked about today, really, our 5-year system plan across the integrated programme of work between local authority, NHS, community voluntary sector and also the business world as well. Tobacco control plays a major part in our poverty reduction strategy and also for the best start in life for our children and young people. Alcohol and drug harms when we talk about mental health and coping mechanisms for people. The impact on the environment and especially around obesity reduction, and that's something that's been highlighted as well in terms of a key priority area for the impact of COVID on the obesity agenda. And then looking at food and our carbon footprint as well. But we felt that many of this was actually managed through other partnership arrangements, but that's not to say that we aren't constantly linking in through the recovery process and the community cell and monitoring and reviewing these areas of work as we go forward. Also, as part of the health impact assessment process, we used the NHS data that was sent to us at the initial start of COVID to look at being able to highlight some of the data sets for each one of our area action partnerships. And I've brought this one to your attention in terms of Chesley Street, the AEP in Chesley Street, looking at their particular data. And as you can see, we've segmented that into our starting well, living well and aging well. But again, kind of being able to focus on the key priority areas of socioeconomic factors, mental health, community assets, and also vulnerabilities and inclusion. So each one of the area action partnerships have this data set, and I've worked with a number of them now to actually look at how this can inform their planning for funding going forward within their local areas, being able to look at the key priorities for action and how we can bolster the community response. So the ask for partners really from the health impact assessment, it kind of provides us with an audit trail for, where we need to go forward. So again, as Amanda's already alluded to, it mitigates against the negative impacts of COVID-19, but also highlights our positive impacts. We have a lot of positive work going on within County Durham. And again, that has been right at the sort of initial response of COVID, but actually going right through the response itself. It's about integrating the key priorities, but also contributing to recommendations made in the report as well, and ongoing monitoring of the data to ensure that we actually can measure the impact of all of our actions taken forward, and also build on the learning to help us support as we kind of enter into our second lockdown and any further lockdowns that are proceeded going forward as well. So from the report, you'll see there's a number of recommendations made, but I just thought I'd pull out a couple of areas here. So again, it's about sharing kind of these the findings from the health impact assessment across all regional groups, across all local groups, integrating that into local plans, again, utilising and refreshing the data on a constant basis, and again, focus on work on the targeted and most marginalised groups within our communities. But also linking our work with the County Durham Poverty Reduction Strategy, also linking our work into the County Durham Mental Health Strategic Partnership, and building work on our resilience in terms of community assets and community networks. And that is very much part of our wellbeing approach agenda and being able to take that forward as well. So the next steps are basically and I have been disseminating the health impact assessment to all relevant partnerships. I've also taken the recommendations as part of the 4 key priority areas and developed that into an action plan. That has now been approved by the County Durham Community Response in terms of recovery and the community cell. We have obviously completed and disseminated the data packs to all of our 14 area action partnerships, and now it's about implementation and looking at how we are contributing to the recommendations over a 12, 24 and 36-month time frame. So that's it from me. I will unshare the screen. Happy to take any questions, Chair.
Thank you very much. You talked there, Jane, about the packs going out to the AAP. I certainly haven't seen it at my AAP. Is it due to go on the next round of boards, or has it just got as far as the coordinators at the moment?
It has been sent to the coordinators. I've actually done a bespoke session with each one of the coordinators as well about how to kind of interpret the data, what their what their data means for them, and how to kind of look at what that means in terms of their focus, I suppose, in terms of addressing the 4 key priority areas. Sometimes mental health might be the highest in an area, sometimes poverty reduction might be highest for an area. So that has been disseminated to area action partnership coordinators.
So is there any way that could be sent to members? Because clearly members are on the board that make the decisions. So is it possible for it to be sent to members?
Absolutely fine, yeah, and I can liaise with the area action partnership coordinators to do that for each area. Also as well, just to mention that the packs themselves, the data packs themselves are actually on Durham Insights as well, so you can actually look them up as well if you need to, but I'll make sure that's actioned.
Lovely, thank you, Jane. I've got Richard Bell.
Thanks, Chair. Yeah, I agree about those AAP data slides, that it'd be good to look at them in advance because there's quite a lot on there if you were just going to be hit with them in a normal sort of meeting. It was just really in terms of leisure centres. It's only last week, I think, or a week before, when at economy scrutiny, the leisure centres were being complimented on how well they were being run, how cleanly, how hygienically, etc., and how safely that they were operating. And one of the issues I feel now is, obviously, we're all encouraged to get outside, but it's not too bad today. But we have had I've been counting here, where I live, we had about 2 sunny days in a month, essentially. So leisure centres were becoming increasingly important and people were using them. and I just wondered how quickly we think we'll be able to fire them up again and get people active and using them again once the restrictions are over, because it does seem a great shame. They had actually got to the stage where they would sort of like established good working practices and people were using them, and now that's all been stopped. And it's kind of difficult to make yourself live healthily when the weather's really crap outside and there's not a great deal else to do except sit inside and eat and drink and watch television, really. So I'd be interested in your comments. Thanks, Chair.
Thank you, Richard. I think Amanda, the Director of Public Health, wants to come in because she immediately put her hand up. So we better let the boss go first, Jane, better we?
Thank you, Chair. I'm sure Jane will be able to add it. And I think, Councillor Bell, you're right. I think our leisure provision, as well as the provision within some of our community sector, has been, really exemplar through this process in terms of aiming to be as COVID secure as possible. Unfortunately, I think due to the national restrictions, there was no choice in that. And I think what we aim to do is provide and promote those other opportunities. Obviously, we do know that the transmission of the virus is much more, in fact, indoors rather than outdoors. It isn't the most, effective in winter in terms of people getting out and about, but we are really encouraging people to do that and to be as active during this time as possible, because of the impact not only on physical health but on mental health as well. And certainly last time our colleagues within Culture, Sport and Tourism did a whole range of kind of reach outs to people in terms of online activities that people could do within their own homes, and they will be repeating that during this next phase. And I think certainly in terms of being able to open up again as quickly as possible, they're obviously doing that planning immediately in the background for when restrictions end on the 2nd of December. So, I think our colleagues in that area, both Culture, Sport and Tourism and Voluntary Sector, have done a huge amount of work. I think during this period we need to really promote physical activity in the outdoors as safely as possible, and what people can do within their own homes. So, Jane, sorry, did you want to add?
No, I think there's nothing else to add there, Amanda. Thank you.
Okay, thanks.
We've got no one else. Councillor Tucker. Tanya, yeah, Amanda said she would continue to send the inside links up to bi-weekly, and that's going to give us, they're going to be 3 training sessions. So I think you're addressing that. So thank you, Jane. Thank you, Amanda. Keep on the good work. You're doing really well, girls. And I'm allowed to say girls, ladies, aren't you? That we're doing well. And obviously, can we accept the recommendations on page 80 and 81? Thank you very much. So we now move on and welcome our colleagues from the Tees Esconway Valley. Jennifer, good morning, Jennifer.
Morning, Chair. I'll just put a camera on.
I promise it is still morning, Jennifer. So over to you.
Thank you very much, Chair. And I guess I'm coming to give an overview this morning, firstly on our, what's happening in the Mental Health Trust as far as COVID-19. And I guess just to start off with, it's been really pleasing to note that mental health has been a thread through everybody's papers this morning so far. So some of the things that I'm going to talk about we've probably already touched on to a certain extent. So you've got a paper that was circulated, and it's not a hugely long paper, but there's quite a lot of information in it. So I'm going to go through some of what I think are the headlines, I guess, and then happy to take any questions that the committee might have. I guess just to start off, because the paper was obviously pulled together a little while ago in time to be circulated for the meeting, we currently have 2 patients on the Lanchester Road site who are COVID positive. So and we're managing those people according with the correct PPE and all of the stuff that we'd have to do. So from a mental health perspective, we haven't really been touched by a lot of patients having COVID within our inpatient settings throughout the whole pandemic, really. We didn't have any at all in the first wave in Durham, but in the second wave we've had some little pockets over the last couple of months. Particularly through September, but it seems to be settling again at the moment, although you don't like to say that because fingers crossed. But like I say, we've got 2 patients. They're on different wards, and they're both being managed looked after in isolation, and like I say, with the correct PPE, etc. We've had more of an impact, I guess, from a COVID perspective. Staff have been impacted more than patients, and that will reflect what Amanda and others have said about it's more, COVID has been more prevalent in our communities recently. So at the moment, again, as of this morning, we've got 13 staff in our locality who are COVID positive at the moment, but all well, all at home, nobody thankfully in hospital with that. So and you know, we keep our fingers crossed every day that continues. So as far as our activity goes, outside of COVID, I guess, what COVID has brought us through the summer and continues through into the winter months is a busy time. I guess we've got our inpatient beds, particularly from an adult perspective, are full all of the time. You know, as soon as we get a free bed, we've got somebody else coming in. So it's been really, really busy over the summer, and that does continue. I think Lee Alexander touched on it earlier this morning on one of his talks, that we have had a cohort of people that have come straight into being admitted into a mental health bed who we've never seen them before. So we've never known them as a community service user, and they've come straight in with quite a high level of need. And so we're monitoring that situation, and we're doing a bit of a look back to try and work out what the issues were that might have brought those people into beds, because it's unusual for people to come straight into service and straight into a bed. So we're doing some case studies, and that's something that I can talk about at a future meeting if people are interested in that. But the acuity is high. Crisis teams have also been particularly busy over this period, and continue to be busy. One of the things that we have done in support of that is we've opened up what we're calling a mental health support line for people with lower level mental health needs. So not a mental health crisis as such, but might need a little bit. They might need a listening service, or they might need to talk to somebody, or they might need to be signposted to a different type of mental health service. And that support line has been opened. It's open now 24/7 for people to ring in and ask. So, and that has taken a little bit of the pressure off the crisis service itself, but it still continues to be a very busy time. So moving through the paper then, we've talked a little bit about this. That's kind of where we are at the moment. The next bit talks a little bit about how we've done a bit of demand planning and looking at predictions for people with mental health needs over the next few years in relation to what's happening with COVID in the community. And you'll see there's a table and some text. So within the narrative, it talks about some of the things that where we know the demand will be coming from for new people entering mental health services. So obviously, the obvious one is the impact of people who've been touched by COVID-19, either themselves or their family members. And that could be just the fact that it's taken them a long time to recover. It could be anxiety about COVID-19 and worry about what's happening within communities. It could also be, sadly, through bereavement from COVID-19. So those are the kind of people that we're going to see coming through the doors. I guess the impact of lockdown, we've heard that again through some of the papers this morning. So the impact of being locked down has significant effects on people's mental health. And they are some of the people that I guess that we're seeing coming through services that have not been known to services before. Because being locked down from your friends, your family, from your local community groups has, you know, as I'm sure you're all aware, has particularly impacted on people. And we are seeing that coming through in some of the reasons why people are accessing services. We've also, from the demand, we've got a backlog of some of our clinical activities, as have other NHS services, because we actually stopped a lot of services in March, April, May time. We've tried to retrieve some of that position through the summer when things were slightly easier. But as we're going through the second wave again, some of our assessment procedures, such as assessments for autism or assessments for dementia, some of those that have to be done face to face and are very difficult to do sometimes with a face mask on. Some of those are building up slightly again in the background. So we need to make sure that we are addressing those in a timely manner, but that will impact on some of the demand over the next few years. Bereavement I've already touched on, and then there's some of the other things that have been touched on in other talks, such as the impact of unemployment and other financial stressors, housing issues, all of those things that we know will impact on people's mental health. So that's some of the flavour of where the demand will come from, or where we predict the demand will come from. There is then a table that's in there which has got some projected figures. And what we've done is we've worked with the local resilience forum, and then we've done some work internally and with other mental health services to come up with some projections for where the demand we think is going to come to. So whether it's going to be into children's services, older people's services, adult services, or learning disability services. And you've got those services split out in a table there. And then what we've tried to do is predict what the total system need for mental health will be. So that could be for anybody providing the service. So not just secondary care, which is what my trust does, but it could be social care, like you've heard from Lee. It could be the voluntary sector. So these services won't necessarily be delivered by mental health services particularly, but I guess it gives you quite a scary number, I guess. So the total number over 5 years into the mental health system is around about 160,000. So that's 160,000 extra referrals into those services. And of those, we predict around 47,000 would come into secondary care. So what we're trying to do at the moment, working with partners, is to try and look at how we can invest more in the front end of mental health services, so into the voluntary sector, working with colleagues in social care, and looking at how we can invest in more to meet the needs. I guess it's that early intervention and that prevention, and to try and put the money out there in the community so that people don't get to need secondary care services in the first place. So that's a lot of the work that we're doing with partners and with our commissioners to try and get some investment into that bit of the system. Moving through the paper then, there's a little bit of information about care homes, and that's not just care homes for older people, it's also care homes for people with a mental health or learning disability need. But we have been working through the pandemic to provide extra support into these homes, to provide bespoke services to individuals who might need it. We're also providing support to the staff who work into those homes, from a psychological support perspective, because I think we know that care homes particularly have been very, hard hit through the COVID pandemic, and that will have had an impact on the mental health and wellbeing of those staff. So we're trying to do that level of support too. But also supporting the service users who live within those homes. We've been lucky enough to get some funding from our commissioners to enhance our older persons care home liaison support team through the summer, and that will provide not only enhanced staffing levels to work into those older people's homes, but also occupational therapists and psychologists. And some of that is to develop additional expertise in managing people who are living with dementia in those homes. So we're providing support to the staff and training and expertise to allow them to be dementia champions and to enhance the support that they already provide into those homes. The next bit in the paper goes on to talk a little bit about resilience and wellbeing hubs that we're involved in, and there's a bit of an infographic. I'm sorry, I'm looking at you guys, I'm not looking at my paper itself, but there's a picture in there. So that work is ongoing at the moment, but there's some money coming into the ICS, which is the integrated care system of which Durham is a part, to fund some of the workforce requirements of having some resilience hubs. But we're looking at a specific community-based hub in the Durham locality in particular, and you've got a little bit of detail about that in the paper. However, those things are still being worked up, and we're still in negotiation with our commissioner colleagues about what that's actually going to look like and how we're going to take that forward. But again, that builds on the model that I talked about earlier about having that real enhanced support in the community-based services rather than being a health-based services. It's a system-based service, and I think that will be quite an exciting initiative once we get that up and running. And latterly in the paper, it just talks a little bit about some of the money that we've been lucky enough to get from our commissioners, mainly non-recurrently, but some of it we're hoping to convert into recurrent investment in the new year. And that's really about, again, that community offer and how we can work better with our colleagues, both in social care, but also in the voluntary sectors, to make sure that the offer is there for anybody that needs mental health support. But it's about our secondary care services supporting community services and not leading that, because, again, going back to the early intervention that we need to promote, and prevention of people needing to get into secondary care services in the first place. So it's a bit of a shift change, I guess, but it's all part of our offer of the there's a new community mental health framework that was published about I'm saying new, it's a good year old, but I guess because of the pandemic, things have been delayed. So it's more about how we can support community services to improve and to look after their own, rather than people getting to such a need that they always need to come into a secondary care service. So that's kind of the focus of our service moving forward. So I shall leave it there, Chair, if that's all right, but happy to take any questions, and I can have a look at my paper if there's anything specific that anybody wants to ask me.
Thank you, Jennifer. So if we take it that we do the COVID now, and then we'll move back to the CCG inspection.
Yes, that's a separate. Sorry, I was going to go on to that next. Is that okay? Sorry.
That's fine. This is the first opportunity we've had to look at that. So we've got Councillor Owen Temple and then Councillor Pauline Crathon. Owen?
Yes, thank you. Thank you, Jennifer, for that very full report. It's a very concerning future, I think, for mental health in the country during this lockdown. I particularly want to ask a question, though. It's mentioned 4 times in your report about moral injury, which is described as frontline and essential workers may have come across difficult situations in the pandemic and be troubled by their own or others' actions that they feel go against good practice. That's quite a worrying thing to have in the report, and I wondered if you could flesh it out for us at all and explain what sorts of things you're actually referring to there.
Yeah.
Jennifer, before you answer, we'll bring in Pauline, and then you've got 2 questions together. Pauline?
Thank you, John. It is a very comprehensive report, and what I would like to bring up is where you mentioned the voluntary sector. We have charities who are working in all our communities, who are helping the local communities and wider areas to access benefits and mental health issues, abuse, even providing food and all that. And I think our charities deserve a big thank you as well. I think without them, I think you maybe would have a lot more people that will be coming with mental health problems. That's all I've got to say, John.
No.
Yeah,
And
that's perfect. Thank you, Pauline. Jennifer?
I absolutely agree. Councillor Crawthorne? Sorry, I'm reading your name wrong. My glasses. I probably need better glasses. But I guess absolutely agree. And a real big thank you to all of those people. But I guess what we need to do, and I think what we've recognised that we need to do, is be a little less precious about our own services and work better and be more inclusive with the community. So I think we're moving in the right direction. It's probably long overdue, to be honest. But I think if you can talk about good things that have come from the pandemic, that sort of focus on joint working has probably been pushed forward a lot quicker than it may have been had we not been through this. But absolutely, I agree. Echo everything that you say. Thank you. So back to the moral injury question. I probably won't explain this very well, but I will try very hard. And I guess there may be others on the call who are more cited on this than me, or might have a more expert opinion. But I guess from a moral injury perspective, there's something about this pandemic that is difficult for health workers in the NHS and healthcare workers, because not only do we have to come to work and deal with the effects of the pandemic and the effects that has on our patients and also our colleagues and our staff members, you come home and it's in your life as well. So it's one of those things that nobody can escape from. And I guess what I understand moral injury to be about is the fact that sometimes some of your colleagues might do things that are either against policy or against guidance, but that might be for the greater good. Or you might actually do something yourself that you know that it goes against guidance, but actually, I guess if we talk about things like people who were unable to go and see their relatives who were dying in the first stage of the pandemic and how difficult that was, and I guess what we see is people who may not always understand or agree with the rules or have a different opinion. I'm not explaining this very well at all. Lee, are you going to help me out here?
I can, if you like. I mean, I was going to be relatively short. A way of describing this, if you think about our professions, many of us actually work, our careers have been about supporting people in crisis and managing other people's trauma.
Yeah.
You can't help but absorb that as a professional, whether you're a nurse, a social worker, a doctor. And obviously, many of us are trained and we have experience which enables us to develop coping mechanisms, if you like, to be able to manage that. Obviously, this pandemic has brought about very different dynamics. And it's an example of that. You're more likely as a professional to feel professionally compromised in certain sets of circumstances. We tend to be working in a range of professions who, routinely have face-to-face contact with our clients, our patients. And in many cases, we're not able to do that now. So if you think, as an example, within my line of work, undertaking assessments in somebody's best interests that lacks capacity pre-COVID, will be sitting in that person's house with people who love them, around them, etc. And you would actually you'd be working within that dynamic, and actually you'd be able to read body language and all that kind of thing, that the atmosphere within the room. Much of that work's happening remotely now, and the person who's at the centre of that, it's difficult to engage them in quite the same way. So some professionals will feel obviously a very strong sense of burden as a result of that. Certainly within my service, I'm sure it's no different for Jennifer and others. We've been doing a load of work during this pandemic, tirelessly sending out comms, and I've been doing vlogs and all sorts of different things with staff in relation to mental health, well-being and resilience, and obviously making professionals aware that they have got our full support. They are doing everything they can. They're learning new skills and they're managing risk effectively, and we're all in this together. So hopefully that maybe helps a little bit.
Yeah, and I guess one of the example I was going to use, Councillor Temple, was the fact that I'm obviously the Director of Operations for the services in Durham and Darlington. So throughout the pandemic, I've been, saying to staff, we need to continue the service. You need to, wear your PPE, go and see these patients, and we don't know whether they might have COVID, they might not have COVID, but as long as you're wearing your PPE, you'll be fine, you're protected. And my daughter is a healthcare assistant in Newcastle hospitals and works on a ward full of, well, at the moment, the ward that she works on has got quite a lot of COVID positive patients. And in my head, I'm screaming that I want her not to be working on that ward. Yet I have to tell my staff that you need to go. And I guess it's those kind of dilemmas. Does that make sense? It's that kind of, you're almost compromised in your own beliefs because you know what you need to do and what you have to do to keep the services going. But actually, from your own perspective, in your head, there's another voice saying, actually, I don't want my daughter doing that, even though, to be honest, to be fair, she's done it since March and she's been perfectly fine the whole time, and she wears a PPE and she's a great healthcare assistant. But I worry as a mother that she, you know what I mean? It's that kind of, so that's what it means. That was a really long, convoluted too.
No, it's actually really helpful, and I think it's really good for us as a committee to hear it, and for me personally to think it, because it's quite easy sometimes to be dry and analytical and forget the strain on people. So I wish you well with your survey and your efforts at actually kind of being aware and looking after people through it. So thank you very much. It's a very helpful explanation.
Thanks.
Thank you, Jennifer. Thank you, Lee. Jennifer, we now move on to the CQC inspection. I mean, the first question that jumps out is, this is now a report of over 14 months ago that the Trust had an inspection. The Trust had 7 months before COVID in which to come to Scrutiny and report back. Why has it taken 14 months for your Trust to come to this Scrutiny Committee? Why did we not come earlier? I'm getting a no from Stephen, suggests I've asked the wrong question.
Chair, it's just referencing and clarifying the fact that the inspections were actually September to November this time last year.
And we didn't get the report until March, I guess.
Right. That's fine. Okay. You see, I always get told off by Stephen when I do it wrong. Over to you, Jennifer.
No, it's fine. And I guess this is just a really brief summary report, Chair. And what I would be happy to do, I have put a link into the full report. I'd be happy to bring a more detailed report back about the Durham end of it to a future meeting, if that would be helpful. I'm just trying to open my
perfect, Jennifer. That's exactly what we want. Thank you, Jennifer. So
I guess just because I wasn't sure what the ask was at this stage, so I've just given you the high level, because as Stephen says, the inspection went on till November last year, but we didn't actually get a report published until March for various reasons. So it took a little while for the report to come out, longer than we'd anticipated at the time. We had some early indication we would have got something in December, but it took till March. So I guess the unfortunate position for TUV is that our overall rating has dropped from good, which has been good for several years now, to requires improvement. And I guess I've shown you in the paper there, there's the table that shows the two areas, the two domains of requires improvement that we were given was the safety domain and the responsive domain. And I guess just for the committee's awareness, the safety domain isn't always about it is about patient safety, but it's also environmental safety issues as well. So it's not always about keeping patients safe as such. Sometimes it's about they don't think our buildings or our rooms are fit for purpose. So there's an element of environmental issue within safety. And that's mainly not due to the Durham and Darlington locality, to be honest, because our buildings are relatively new, but some of our estate in the North Yorkshire and York perspective was a little older at the time of inspection, although that has since moved on with the opening of the new hospital in April in York, which has alleviated some of those concerns that the CQC had for some time. And I've given you the specific course services underneath that. So obviously green is good and amber requires improvement. So you can see there are 3 ambers in that table there. So it was the crisis services and the health-based places of safety. It was our wards for older people with mental health problems and our community mental health services for children, who all got the amber rating as opposed to the green there. I guess we're in the middle of doing an action plan for the CQC at the moment. Some of that has been a little delayed due to what we've been going through over the summer with the pandemic, and some of the environmental works, for instance, that needed to be undertaken on our wards. Some of the fixtures and fittings that we needed to buy came from other countries, and that was delayed due to coronavirus. So some of those works are ongoing at the moment. So that just gives you a flavour of things that have been delayed slightly. But we are, as far as Durham and Darlington go, we are on track with our actions. There were a couple of actions that are behind schedule in Durham, and they're due to the wards for older people services. And it's just about how we monitor things or don't complete things correctly always on our electronic patient record. And we've got audits that are ongoing with matrons at the moment, and we needed to correct the patient record. Our IT team are correcting the patient record to make it easier for people to use and make sure the correct fields are filled in. So again, that work has been going on through the summer, and that will continue. So I have, Chair, as I said, I've put a link into the full report at the bottom if anybody wants to go and have a read of that. But what I'll do is for the next, whenever the next committee meeting is, I'm happy to do a more detailed paper on the Durham actions, because they're not all actions for Durham within that high level summary that I've given you, and where we are against those. And I'll be happy to do that for next time if that's okay.
Thank you, Jennifer. And I'm one of them boring people who actually went and had a look at the report, and yeah, there is a lot of it's not to do with Durham. Stephen, you requested to speak.
Thank you, Chair. Yes, just to provide a little bit of context for the rationale for this report coming to committee. I'm going back 12 months or so, when members will recall we had a series of reports updating members on things like the crisis service, and there was also some media coverage around issues within the CAMS service, which prompted kind of a lot of the CQC inspections. Just to say that obviously the CAMS issue was discussed in detail at the last meeting of the Children and Young People's Overview and Scrutiny Committee, to which a number of members of our committee also attended. So the rationale for today's report is to just place in context the remaining services that do fall within the remit of the Adults Wellbeing and Health Overview and Scrutiny Committee. And I think that the suggestion to bring a more focused Durham perspective report to a future meeting of the committee would be welcome, Chair. Thank you.
Yeah, thank you very much, Stephen. Fully agree. Well, Jennifer, everybody's ask their questions. So thank you very much, Jennifer.
Thank you very much, Chair.
No, thank you. And I should have said welcome to Durham, because I think it's your first time at the committee, and I hope you come on in the future. So we now move on. We've got no any other business, so that's the end of the meeting. Would I ask people to remain at this moment in time? Democratic Service will